afternoon, everyone. This is last but one talk, as Pranay has said. In this, I would like to combine whatever we have gone through in the last 3-4 days and put them together. My objective is how to run safe ECMO by combining all the available information information so far. What are the principles of safe practice, and about the importance of thorough learning, selection of cases, prevention, and early diagnosis of complications. So, ECMO is based on sound principles. As you appreciated, whatever you learn, still there is a need to re-emphasize again and go through that, learn in more platforms, national as well as international platforms, to learn new things from others. So it is based on sound principles. It is a science. There is a lot we need to know, and there is a lot that we don't know as well. One of the examples being coagulation guidelines, how they are being changed from time to time. The further research that is happening in neuro metabolism, auto regulation, cerebral auto regulation, etc. These are some of the examples. So in each and every field there are changes taking place, and it is important for us to know about it. So learning to keep ourselves up to date, team building, safe practice, not to emphasize anything more than that. This is very, very important. And we learned just now adoption to the regional settings. Different settings in different countries are varying. So we need to pay attention to that and learn with adaptation to the regional settings. Research and perfection to take it forward. We came a long way. As Pranay said, with our passion for ECMO, we met on one platform in 2010, organized for many meetings in the last 13 years, and went forward in imparting whatever little we know for spread of ECMO in this country. There were people who were laughing at me at that stage. I have been doing ECMO for nearly a decade by that time in UK, but one of the usual questions I used to face whenever I talk about ECMO here is, how much does it cost? And there is nothing for me to translate. And when I say in terms of 3,000 pounds per day, then they say, oh, you are joking. And then, they move on. They don't take it very seriously. But as Pranay said, we trusted. We trusted it is going to happen someday, and let us take it forward. Cardiac surgery didn't come to this extent within 5 years. Today in India, cardiac surgery is available for many affordable patients, many, for a middleman, just to say. But probably the situation would have been different 15 years ago. We are hopeful that same might be the situation with ECMO as well. As Pranay rightly put the cost down. In future, in 4 months, 4 years time, 5 years time, things would be different. So this is one of our patients from Krishna Institute of Medical Sciences. When we started ECMO program there in 2014, how many people are needed to do safe ECMO? Probably more the merrier as a team, but the essential ones are a handful of dedicated men and women who have passion for ECMO. The pillars of ECMO being ECMO specialist nurses, ECMO intensivist, ECMO surgeon, and ECMO perfusionist. These I consider as the basic minimum for running the ECMO. Because complications can happen at any point of time. Surgeon can be handy and within the limits in the surroundings whenever we need to, but it's always ideal to have a cardiac surgeon in the team as well. They should be highly trained, knows what to do with good experience, commitment, communication. There is nothing to replace practice. So our advice is from this: once you take the knowledge back, keep studying on that. Don't go for putting patients on ECMO right then and there itself, but practice. Go for the centers where ECMO is being done. Be part of the team for some time, and then take it forward. we're not supposed to say about ECMO Society of India program here, but there is a fellowship program which we have been running for 1 year. It is a 1 year course which imparts more energy and skills into ECMO practitioners, ECMologists who want to become locally, something like that. It need not be that, it can be anything else to give you more experience with the cases before you do. It is a team game. From my point of view, I believe in ECMO being ECMO as a department rather than a neonatal ECMO, pediatric ECMO, adult ECMO, because ECMO is all to do with the experience. The more number of cases you have, the better you will be. So if you only do neonates, you might get 2 cases in a year. If you do only pediatrics, you might get another 2 cases. But if you do a combination of everything, then there is a possibility for you to develop a good program. So what we did in Hyderabad was, me as the ECMO director, we had pediatric intensivist, adult intensivist, cardiac surgeon, pediatricians, nephrologists, anesthesiologists, cardiologists, radiologists, etc. in our team, along with our specialist nursing team which we have built up. So with that, everyone will contribute. When an adult case comes, this team along with the adult intensivist, that will be part of it. A child is there, then the pediatrics and the pediatric intensive care will be part of it as well. So I think that it will be more fruitful for our countries if it's a combined ECMO program rather than subdividing into neonatal ECMO or pediatric ECMO, etc. So ECMO specialist nurses are the pillars. They should know enough. If they commit any mistake, I definitely take. It is due to lack of training imparted by me. So they have to go through this program more and more, and please conduct courses within your departments as well. Once you go back, simulation is there for you to work as a team. That can make things better. So though we thought this is the ECMO team, but as you have been looking after a handful of patients, at some point in the run of ECMO, even the patient becomes part of the ECMO team too. Extended members, the most important one being blood bank as well, as you don't know when you will be setting into massive blood transfusion strategy. It is not very common. Once blood is required for the time of going on to ECMO, afterwards depending on the loss and the surgical need, etc., then only you might be needing blood, but usually you don't need blood that often too. So in your unit, you develop your own order sets or checklists when you start your own ECMO programs. Something, for example, like instructions for the ECMO mission priming, for ECMO circuit settings, daily parameters, blood products, massive transfusion protocols, radiology studies, and anticoagulation and associated laboratory monitoring and adjustments, etc. Develop your own ECMO carts, like resuscitation carts we prepare. Like that, you should prepare your own ECMO carts with cannulae and other equipment, disposable equipment needed for all ages, depending on your clients. So you should develop your own ECMO cart. Purpose-built ECMO transfusion trolleys are available, but they are very costly. So that is the reason we build our own ECMO trolley, transport trolley. Ordinary transport trolley can be modified for putting ECMO console onto that. So once your program builds up and you tend to retrieve patients from the neighboring hospitals from a distance, you should try to develop your own ECMO transfusion trolley, ECMO transfer trolley. That will be transport trolley will be very, very helpful. The most important point is initiation at the right time. I'm sure we discussed this enough in the meeting, and that is one of the take-home messages for you. Optimal conservative management should be done before going on to ECMO, from economic reasons, from financial reasons in our country, probably elsewhere as well. So just repeating this point though, what decides your meaningful survival is perfusion to the vital organs. Till the tissue metabolism is going fine, tissue oxygenation is being looked after, as indicated by trends in the numbers such as lactate. So your patient can be looked after, to be continued to look after, by paying less attention to the numbers if they are not optimal. Awake patient, that is important to intermittently try to reduce the sedation and keep them comfortable but awake if possible. Multi-organ dysfunction, if it is not there, that is also a good indication. Supporting the families is important too. We discussed about this importance yesterday. Counseling on a daily basis, informing them about the progress is important. Avoid accidents, learn from our experiences but also from others' experiences too. Don't let it happen to you. Things have happened. One of the examples being insertion of distal perfusion cannula. So I have seen people who were adamant. These are very experienced cardiac surgeons, and they didn't want to put cannula, distal perfusion cannula, hoping that when they looked on the ultrasound there was sufficient space around the cannula, but ultimately those patients ended losing the limbs. So never ever take it lightly. It is a must to go for distal perfusion cannula when you are inserting femoral arterial source in VA ECMO. Realism and communication are important. I cannot stress enough regarding preventing and treating infections. We live in a bacterial world where we will never be able to stay ahead of the mutation curve. This has happened and this will continue to happen as well. As I was sharing with one of teams earlier on, if an organism is sensitive to crystalline penicillin, probably we are using meropenem or carbapenem to kill it. We are using Brahmastra to kill something which can be treated with crystalline penicillin. Unfortunately, we're not encouraging organisms to lose their plasmids, which drug resistant plasmids. This can happen. In my situation, it happened within 3 months' time. When you downgrade the antibiotics, when you make sure your environment is made best in the first instance, and use less powerful antibiotics as needed, in those cases, in 3 months' time, in my environment which contained 70% drug resistant bacteria, we started seeing sensitive bacteria after 3 months, if at all we see sensitive bacteria. So bacteria change their characteristics. Even if it is a penicillin sensitive organism, if you threaten it with carbapenem, it is going to develop resistance. Even if it is a more powerful antibiotic also, it is going to develop resistance, because that is how it learned its ways. So we cannot underestimate them. If you look at the Western countries, and from this aspect especially, penicillin is being used even today. But why not we? There are periods when the ECMO circuit is run without antibiotics. Why not we? I don't want you to do it in the first instance. First, change your environment. Once you change your environment, then you can think about it. You give a thought about it. Proning is very important, and I have seen how magnanimous colleagues are in resource limited situations. When I didn't have some expertise to deal with a patient and requested for some other corporate hospitals, yes, colleagues did come and help at no cost. They came and they helped. So help is available around as well. So just two of these common issues we come across about suction. People tend to do inline suction as so that is okay, but when it is difficult to clear the secretions, then go for open suction. That is very much needed, and clearance of airways is one of the best ways to move forwards in difficulties like completely consolidated lung. Bronchoscopy, there was one time we were using alternate day bronchoscopy. I don't know, that is for clearing the secretions. I don't want to make it mandatory, but there is a need for it. Use it with discretion. I was working in a hospital where each bronchoscope is being used on 15 on 15 patients. So when the rapidity is so much, it is very difficult to clean that particular bronchoscope. You might put it in Sidex and take it up, but unfortunately it doesn't kill all the organisms. In UK, we are not allowed to touch or ask for the bronchoscope for the next 3 hours after usage. So those are the strict criteria they will be subjected to before it is returned for patient use again. So if you want to use a bronchoscope, try to have one bronchoscope for your unit itself, ECMO unit itself, not mixing it with the general population. So these are small things, but there were times by using the bronchoscopes which are being in the rotation, we introduced infection in our own patients as well. So to prevent these things from happening, just pay attention to that. ECMO lung is very consolidated, solid lung. So if you insert any of the sharp instruments in that, and if there is a development of the bronchopleural fistula, that becomes very difficult for you, and patient might pass away as a result of this bronchopleural fistula remaining forever. So I prefer to use blunt instruments such as blunt chest drains rather than a sharp chest drain. If I need to drain anything in case of pneumothorax or pleural effusions which demand drainage. So small low cost interventions such as usage of disposable gloves whenever you touch a patient, this has been proved to be very helpful to the extent like 25% incidence of reduced incidence of infection was noticed by using disposable gloves. So in your chain of prevention of infection, and give importance to each and every step in that, pay respect to that, and move forward. So infection is very important. I was really surprised, as Pranay was saying, sometimes it surpasses the cost of ECMO or the patient stay per day. Sedation, minimal sedation. This is the girl I was telling you earlier on, 2-year-old on ECMO, awake ECMO. So it is possible in children as well, but you have to select popularly. This fact is never being written anywhere. It will never be written as well. What I am talking about, the window of opportunity. ECMO is not luxury. It is comfort from my point of view. When your patient is not being ventilatable, you are seeking an alternative mechanism called ECMO. With medicine. So engage with them and make it a win-win situation together. So funds, we discussed enough earlier this morning also about from having a goodwill with the administration, charities, and family role, safe innovation. So that is a way to move forward. So towards the end, strategy, have a plan, select ideal space or unit where you would like to maintain ECMO, continue ECMO and maintain asepsis, zero tolerance to infection. Consult colleagues for their expert advice. There is no shame in it. ECMO specialists are the pillars. Whenever you have problem within in India, we don't mind consulting ourselves via the WhatsApp group, and we give answers to the extent we can. Have your checklist, equipment, develop your own transport program, and do uh, continue with your networking. For me, all medical professionals are artists. My favorite artist is Raja Ravi Verma. We may not go to that heights, we might be different heights, but medicine is an art as well. Lastly, don't forget the roots. From here, ECMO Society of India, ELSO, as we all belong to ELSO chapter, uh, including the Middle East, and ultimately ELSO, which is doing its best to propagate ECMO throughout the world. So by holding hands and developing together, we can bring changes. So practice safety culture, thoroughly do receptorship at the right place with the right numbers moving on, and learn from people. Building teams is important, learning from experiences. Continue with the simulation exercises, research and innovations, and continue to maintain humanitarian touch. Thank you very much. But I would like to emphasize the message from our great ex-president Abdul Kalam. Don't always read success stories, you will get only the message. Read failure stories, you will get you will get some ideas to get success. Thank you for patient listening. If there are any questions, I'm